much. Let me first of all say what a pleasure it is to be here. I'm grateful for the invitation. I'm only too aware that I'm not a rising public health researcher, but we can't all be rising. Right, jumping ahead. An outline, first of all. There's two parts to my talk. In the first part, I'm going to review some challenges in using cost-effectiveness evidence in order to assist decision-making. The three challenges I'm going to look at, the first one concerns identifying appropriate, and I stress appropriate, cost-effectiveness threshold. The second one concerns refining our methods of valuing the benefits from the healthcare so that we better capture the benefits of the interventions. And the third one is a really important issue, and it's the ever apparent tension between affordability and cost effectiveness. And in that excellent presentation we just heard, we had a nice example of that arising. Second half of my talk, I'm going to draw on my own experience in the UK of using economic information to try and inform decision making. I won't be apologetic about using the UK. One, it's what I know best about, and so that's a good reason to stick to what you know. But there's another reason. The UK is perhaps at one end of a spectrum in using economic information to inform decision making in the healthcare sphere. And so it's quite interesting perhaps as a contrast from many other countries. So first of all, the issue of determining an appropriate cost-effectiveness threshold. It might be a single threshold, or it might be a threshold range, or you might have multiple threshold points. There are a number of potential sources for the identification of a cost-effectiveness threshold. Sometimes it's argued you could look at the threshold implicit in past decisions. Now, while there are some technical challenges in identifying implicit thresholds, my major objection to using this as a source is the past really a good guide to what you want to do in the future? And I'm not convinced it is. The second main approach that's advocated for identifying appropriate thresholds is to estimate a societal willingness to pay for additional health benefits. So in this context, it could be possibly for additional QALYs or DALYs. I'll tend to refer to QALYs because that's what's overwhelmingly used, at least in the UK. And so the issue is, can we identify a willingness to pay among the general public for additional quality-adjusted life years? Third approach that's sometimes recommended is to choose a threshold value that's some sort of multiple of gross domestic product per capita. And of course, this is associated with WHO, although to my mind they seem to be backing away from it a little bit more recently. And if you look at the most recent issue of the Bulletin, there's a defense saying, oh, we never really meant you to focus too much on cost effectiveness thresholds. There are many other factors to be taken into account. I hope that's something we all always knew. That it'll be a theme I might return to. The fourth approach, and this is the one I favor, is that you might want to focus on the cost per unit of benefit of the services that are being displaced. So in trying to identify an appropriate threshold with which to judge whether you want to adopt a new practice, you want to think about the consequences of adopting that practice, and in particular, if you're going to then displace existing activities, what are the benefits that you're losing? You could call this a health opportunity cost approach. I think this has got the greatest claim to our attention. I think when we're looking at this issue of appropriate threshold, we have to think about where the resources are coming from in order to provide, let's call it a new service, perhaps a new drug, or it might be a new diagnostic test. We'll just be looking at diagnostic tests. Where are the resources coming from? Now, if these resources are from existing consumption, and so they're coming from outside of the health sector, then I think it's wholly appropriate to consider the societal willingness to pay for health benefits. And you might possibly use a value related to income per capita as well as an alternative. But if you're in the situation where there's not new resources coming in, but you're looking at ways of spending your existing budget, and this, I would argue, is the situation that we are most frequently in. If you're in that situation, I think it's imperative that your focus is on what you're giving up elsewhere in the health sector. And I'll try and persuade you to that, if you're not already persuaded, through this talk. If you're going to pay attention to cost effectiveness as one element of your decision making, I think it's very important that you're confident that you're measuring both the costs and the effectiveness appropriately. And generally speaking, we think that we can measure the costs quite well. There are some exceptions. The area where we tend to have much greater difficulties or face challenges is with respect to measuring the benefits. And partly as a consequence of this, there's been a huge amount of interest in recent years in trying to refine our measures of benefit. And there's two broad approaches that are apparent. One, focusing on QALYs, is to stop regarding all QALYs or quality-adjusted life years as being of equal value. And in other words, move to a situation where you weight the QALYs, and you weight according to some characteristic, perhaps, of the recipient. The most common example of this is weighting according to the severity of the condition. So individuals with a more severe condition, you might value QALYs that they gain more highly than other individuals. The other strand to this literature is to try and broaden our measure of benefit to include a wider range of consequences. An example of this might be trying harder to capture the impact on carers and family members. NICE in England, National Institute for Health and Care Excellence, did in fact propose that you might weight according to the burden of illness, and their candidate measure for burden of illness was proportional QALY loss. In other words, you'd look at the QALYs that this patient group were losing compared to individuals, same age, gender, who didn't have that condition, and you look at the proportion of QALYs they're losing. So if you're losing half the QALYs that other individuals will experience, that would indicate quite a serious condition. On the other hand, if you're losing a 20th of the QALYs that other people would benefit from, that's a much less important condition, and the QALY gain could then be more weighted less highly. There have also been various proposals for capturing the wider societal benefits. In England, the Department of Health came up with a very interesting method, which didn't get very wide support, but it was actually a very interesting attempt to capture all the impacts of a health intervention and spending on that intervention on the wider population. The third challenge in this area is this fundamental one of the tension between cost effectiveness and affordability. It's entirely possible, and we see it again and again, for health technologies to be assessed as cost effective, but that doesn't then necessarily mean that they are affordable. And the problem here is there's no automatic link between the size of healthcare budgets and the cost effectiveness of healthcare spending. There may be a link sometimes in the sense that if you've got lots of opportunities to spend additional healthcare resources to produce benefit, you might be able to persuade a Ministry of Finance that the budget should be increased. But I wouldn't lie awake waiting for it. There's just no mechanism. And the problem then arises that the whole idea of cost effectiveness gets discredited. Because if people keep coming up with new drugs and new diagnostic tests or new programs, and they say, look, it's cost effective, I demonstrate the additional gain for the resources invested. And if this keeps coming up against the affordability of it, and I come back to the idea that the talk we've just had highlighted this then really undermines the credibility of the cost effectiveness information being a useful and valuable input to the decision-making process. This is particularly a problem if you use as a cost effectiveness threshold some multiple, perhaps 1 times or 3 times gross domestic product per capita. An alternative approach is suggested that you set your threshold, and excuse the split infinitive, you set the threshold to optimally exhaust, or to your fixed budget, or in other language, maximize the health gain you get from your fixed budget. Now, if you do this, this greatly reduces any tension between cost effectiveness and affordability, because this approach links the size of the budget to the availability of cost-effective opportunities for spending that budget. Turning now to the UK and decision-making practice in the UK, I've got to make a sort of conflict of interest statement here. I've been on the NICE Appraisal Committee looking at new drugs for 13 years. I was on the Scottish Medicines Consortium for 6 years. National Screening Committee, I'm excused. Safety of Blood, Tissues and Organs, another committee. I've been the health economist for 8 years. And the Joint Committee on Vaccination and Immunisation, I've been advising them in a couple of roles for, I guess, over the last 3 years. So I'm completely conflicted. If I don't believe that it's important and valuable to consider cost-effectiveness information, I've been leading some sort of double life. Now, I assure you I haven't been leading a double life. It's rather more glamorous than the life I lead. I truly believe that you can use cost-effectiveness information to improve decision-making. And so I'm coming from that position of belief. I use the word belief because it's virtually impossible to demonstrate that it does improve decision-making. It's an act of faith. But most people have something they believe in life, and why can't I believe in cost-effectiveness? So let me just take you through these organizations, and I'm not going to give you a blow-by-blow account of how they operate, just I want to bring out how they, to some extent, use information on cost-effectiveness, and to highlight that they're doing it in different ways. There isn't just a single way to use cost-effectiveness information. NICE are a very successful organization. They've survived. And they've survived under different governments. They've survived in an area where organizations are frequently set up and then disbanded or reformed. But they've endured. As a consequence, they've now gathered a huge range of activities as part of their remit. They're probably best known for their clinical guidelines, but really the thing that also gets most publicity is the technology appraisal guidance. These are decisions largely about new drugs and whether or not the NHS should provide these new treatments. But they have a wide range of other activities. I'm going to focus on technology appraisal guidance because this is where economics is used to the greatest extent. It's also true that clinical guidelines and the public health guidelines and increasing the highly specialized technology guidance builds on economic information. I won't read all this out, but there's various things that NICE are expected to take into account. But in technology appraisal, what this really boils down to is answering the question, if we introduce this new medicine or new health technology, how effective will it be in practice? How well will it work? And the second question is, will this represent good value for money, given our other opportunities for spending the health pound or the health dollar? NICE has two categories of guidance. They can recommend a drug or they cannot recommend. If they do recommend it, they have to indicate what they're recommending, for whom, when, etc. NICE can only recommend within the marketing authorization of the European Medicines Agency, but they can restrict the indication. So they can recommend for a smaller group. NICE guidance is very important. Health professionals are expected to take NICE guidance fully into account when they exercise their judgment. In other words, doctors can do what they like. So long as you can find your peer group who won't criticize you too much, do what you like. However, the NHS don't have that clinical freedom. If NICE make a positive recommendation, it's mandatory. So by law, the NHS must make that health technology available to the population, and normally within 3 months of the positive recommendation. All NICE guidance is reviewed every 1 to 3 years. This doesn't mean you go through a detailed review of the evidence again, but simply you ask the question, has anything material changed, so we should re-examine our decision. NICE has a cost-effectiveness threshold. There's an explicit £20,000 to £30,000 threshold range, £20,000 to £30,000 per QALY, and that's been in place since 2004. NICE reviews its methods from time to time, and in the 2008 upgrade of its methods guide, it tried to clarify situations in which it thought it was appropriate to be willing to pay more than 20 to 30,000. And two best examples of this are situations where the health-related quality of life has been included, but perhaps not fully captured by the economic modelling. And so there's a feeling that some of the benefit has not been reflected in the incremental cost-effectiveness ratio. Another example is where new technology is particularly innovative, and as a consequence it demonstrates some distinctive benefits which may not have been fully captured by the QALY, or Quality Adjusted Life Year. On the other side of it, an additional reason was identified for not being willing to pay a higher cost per QALY, and that is in situations where the uncertainty is greater. And so as the evidence becomes more uncertain, committees are expected to be less willing to spend more money to purchase that particular benefit. There's one interesting addition to all of this, came out on 5th of January 2009, and it's a supplementary guidance for something called life-extending end-of-life treatments. Life-extending end-of-life treatments. The criteria have been revised on a number of occasions, but they now represent two criteria to be fulfilled in order to qualify as life-extending end-of-life treatment. And the first criterion is that in the absence of this treatment, this patient group has a life expectancy of less than 24 months, less than 2 years. The second criterion is that there is sufficient evidence to indicate that the new treatment offers a life extension, and that life extension is normally of additional 3 months. Now, if these two criteria are met, appraisal committees are obliged to treat the QALYs gained more favourably. And to date, there have been 50 situations or occasions when the criteria have been met, and the decisions are consistent with the £50,000 threshold. Incidentally, all these treatments that have met the criteria are cancer treatments. And they're not all cancer treatments, they're a subset of cancer treatments. Raises an interesting question, is it appropriate to systematically advantage these patients over all other patients in the NHS? Moving on, the Scottish Medicines Consortium does a similar role to NICE, but not quite as broad, does it for Scotland. The SMC, they require robust clinical economic evidence to be presented. They require a demonstration of value for money. Interestingly, SMC doesn't have a formal cost-effectiveness threshold, so it's unstated where their threshold lies. Another interesting aspect of SMC is that they quite explicitly have identified from an early stage a list of what they call modifiers, reasons for being willing to spend above this unstated threshold. So for example, I won't go through the whole list, but take the first one. If there's evidence of substantial improvement in life expectancy as a consequence of using the treatment, and this life expectancy is anticipated to be lived at a reasonable quality of life, that would be a reason, a positive reason for being willing to spend a bit more per QALY. Another example is a situation, you could say, of extreme clinical need or unmet need, the absence of any therapeutic option for this patient group. So if this new treatment is the first genuine treatment that has a reasonable prospect of providing benefit, then you might be willing to spend a bit more to get that benefit. There's other reasons, you can read them yourselves at your leisure. Well, not the leisure now. I believe all these talks will be online at some point, yeah. So at your leisure, read them. Another example, National Screening Committee. So National Screening Committee advises the 4 UK countries about all matters pertaining to screening programs. And they have quite a long list of criteria. One of the criteria for approving a new screening program. Where does your life go? That's 20 minutes gone like that. If it's been as exciting for you as it's been for me, you'll feel the same way. Well, one criterion is that notion of value for money. The cost effectiveness evidence. Is there evidence that introducing this screening program will be cost effective? It's only one of the criteria, and if you review the actual decisions, for example, just taking 2016, and I won't read them all out, but in 2016, the National Screening Committee reviewed a whole series of proposals for screening, muscular dystrophy, adolescent idiopathic scoliosis, etc., and it didn't find in favor of any of them. And in not finding in favor of any of these new screening programs, it never mentioned cost effectiveness. And so what happened is they're applying their criteria sequentially. So the National Screening Committee is more concerned with, does a suitable test exist? And if such a test does exist, screening test, is there a reasonable prospect it will influence treatment and eventually outcomes? Now, if you tick all those boxes, then the screening committee might start worrying about value for money, but none of these managed to get that far. SABTO, Safety of Blood, Tissues and Organs. This is another UK-wide committee. Again, it looks at a wide range of criteria when making its decisions, one of which is the cost effectiveness of the interventions. What does a SABTO recommend, or what sort of topics does it look at? Well, for example, making platelets safer. So pathogen inactivation of platelets, or instead of obtaining platelets from a pooled blood donation, we pool the blood donations of 4 donors and extract the plasma. Instead of doing that, you could, through apheresis, extract the plasma from a single donor. And the implication there is there'll be less risk of transmitting any disease with a single donor, but it'll be more costly. The one we're currently exercising our mind is screening blood donations for hepatitis E virus. We don't currently do this. Should we? And another two are rather UK specific. Those of you who are rising public health researchers are probably too young to remember mad cow disease or variant CJD, but back in the 1990s it was a particular problem and recognized as such in the UK, so much so that we we resolved the problem by killing every cow in the country. But there may be a legacy, because we know very little about variant CJD, and for that legacy, should we introduce policies to make our blood supply safer? So, for example, should we have prior infiltration of red blood cells? Or should we import fresh frozen plasma in order to reduce the risk of variant CJD? Well, the answer to the first one was we decided no, that wasn't a good use of resources. The second one, we do. For children, we routinely import fresh frozen plasma from other countries and don't use our own. I want to emphasize with SABTO, in my remaining minute, that SABTO has a decision-making framework. Now, this is all probably a bit small for you to read if you're at the back, but as part of this decision-making framework, value for money is right in there, cost per quality is in there, but there's a recognition that issues around the adequate supply of blood components, hazards for patients, operational considerations, external considerations, legal considerations. There's a wide range of other things that have been considered, and so cost effectiveness is just one part of the story. And to wrap up rapidly, finally for our set here, we've got JCVI, the Joint Committee on Vaccination and Immunisation. Again, it's a UK-wide body. Again, it considers, among other things, the cost effectiveness of immunisation strategies. One very interesting aspect of JCVI is the way it treats uncertainty and the cost effectiveness threshold. To be cost effective, or judged as such by the committee, the most plausible ISA must be no more than £20,000 per quality. And to take account of uncertainty, there shouldn't be more than a 10% chance that the ISA is in fact over £30,000 per QALY. This is quite a rare example of really trying to build in uncertainty, consideration of uncertainty alongside the threshold. I won't go into the details of meningococcal B, but it highlights exactly this use of uncertainty and cost effectiveness threshold. So to wrap up, there's lots of different ways you can use economics to inform rationing decisions. The UK is at one extreme, definitely. That doesn't make it wrong, but I'm not here to say the UK does it right either. Thank you very much.